Welcome, and so happy to have everybody here for our 7th chapter of Bouncebacks Critical Care. And I will say that I have decided to take a summer break, and that's for several reasons. One is that the first Monday in July is July 4th. So, you'd have to really love critical care to attend that one. And the second thing is, we'll build some more excitement in the fall and get things going with Chapter 8 on September 5th. So, easy to sign up. EM Bouncebacks is my website, and you can obviously go straight there. So I wanted to start off by first thanking our fantastic panel, and I'll just introduce you guys in alphabetical order. So Raj JEsudoss is pulmonary crit care, and he is at my hospital at Adena Health Systems in Chillicothe, Ohio. Kay Moody, she is a emergency physician in Washington, and she is the founder of EM Docs, is probably best known for. So you have attended every single one of these, KK. Great to have you. Mike Pallaci, we have worked together for quite a while. Mike is actually up now at SUMA in Akron, but probably for the last 10 years, as far as starting with conferences, and then had a really fantastic time working together, put on some really nice conferences together, and done some really cool research together too. And then the man who needs no introduction is Scott Weingart, M-Crit podcast and Chief Division of Emergency Critical Care at Stony Brook Medicine. So thank you guys all so much for joining. And I have to say that this case we're doing now is a super important case because it deals not as much with diagnosis. And we'll get into the diagnosis part of it in a little bit because the diagnosis obviously is important, the precise type of diagnosis, obviously CHF versus COPD exacerbation or, pulmonary embolism. Obviously, that's a super important thing. But we're going to really delve into the management of this patient and the critical care aspects of that because as you will anticipate with a patient who is being presented on Bounceback Critical Care, there were other issues involved. So without further ado, I'm going to just sort of jump into the patient's story. And uniquely, we're going to spend almost no time with the initial visit. And I will just tell you that this patient, and his name is Doug, he's a 56-year-old man and a pretty healthy guy. He is a worker. He owns his own business, does outdoor work, but he visited his primary care provider and no huge surprise, had 5-day history of cough at the time, was prescribed a antibiotic and a cough syrup. So, something that happens all the time in primary care. But that's all I'm really going to tell you about the primary care visit. Not because there's more to tell, really, but because the story really gets interesting about a week later when his cough worsens and his wife sees him at the table and he is not looking too good. Now, I'm going to break away for just half a second here to share with folks the fact that if you want to and have not yet done this, if you scan your phone with this QR code, you will be able to get your 1 hour free CME. And I will tell you also that none of our speakers today have any interest as far as any conflicts of interest within this discussion. No one owns ventilator companies. No one has vested interest in IV fluids or oxygen. We all have interest in that, but not financial interest in that. So if you scan your QR code in here, I'll give it just another second to do that. Very, very easy. Pretty much just need to put your name and email address in here, and then you'll get your 1 hour of CME. So there is that information. No relevant financial relationships. Wanted to keep this up here for a second. So, okay. All right. So this is the initial visit, and then the patient bounces back, and he is at his bedroom or kitchen table. His wife calls EMS. They find him diaphoretic with an O2 sat on room air of 71%. Again, this is a healthy patient who doesn't use oxygen. They put him on a face mask, but they have minimal improvement in the oxygen saturation, and so they convert him to a CPAP. They check his blood pressure, and it's 85 over PAP. They put 2 IVs in and take him immediately to the emergency department. So we're going to jump right in with our panel here, and this is his history as documented by the emergency physician, obviously not at the time that he first got there, but when they went back to their desk, right? So so Mike Pallaci, you are the chapter author for chapter 7 here. And I just want to sort of start things off. And we see shortness of breath patients all the time. And in the ED, we can't afford to be usually right, but usually this is something like a COPD exacerbation or pneumonia, even CHF in patients with a history, maybe even PE or ACS. And I'll tell you right off the bat, this is going to be just a little bit different. It's a pretty healthy guy. He got the antibiotics 5 days ago for the cough, but just sort of walk us through where you're at seeing this guy at the bedside. a little bit more concerning in some ways because there is some diagnostic uncertainty right up front. What's your problem list and what's your initial approach, Mike?
Well, I mean, this guy's, I mean, he's pretty clearly not your standard community-acquired pneumonia COPD patient, right? I mean, he's severely hypoxemic, he's hypotensive, he's got chest pain, shortness of breath. I mean, this dude's critically ill, right? So, like anything, we're obvious, it all starts with your H&P and then using that information to develop and then prioritize a differential. So, um, let's think through some of the more likely etiologies for a guy who, like Mike said, is relatively healthy, but has had progressive cough, and now he's in respiratory distress, and he's got hypoxemic respiratory failure, and he's in shock. So we can think of it in terms of categories, but some of them are going to immediately drop off the list or at least move to the back of the differential. Airway issues like masses or mucus plugs, epiglottitis, that could explain some of his symptoms, but they don't really fit. The clinical picture doesn't really fit those very well when you consider all the information available. Same thing with the most common cardiac issues. I mean, this doesn't present anything like an ACS or anything like that, but there are some important diagnoses like myocarditis, endocarditis, pericarditis with tamponade that can have a lot of these clinical findings that we're seeing. Heart failure is also a consideration. Other systems like CNS issues, if you're considering botulism, GBS, myasthenia gravis, other cardiac or other systemic or vascular issues like dissections or DKA. But again, none of these really fit the clinical picture very well. The respiratory system is really where the money seems to be here, right?
Okay, yeah. So we have this respiratory issue going on, and he has this pretty significant problem. I mean, this guy is on CPAP, and he's still not statting well. He's hypotensive, and he has complaints anyway of chest pain and shortness of breath. These are initial vital signs, and this is as he comes in with the EMS. So Mike, in just like a sentence or two, just spout off, like if you're able to give verbal orders, what are the initial verbal orders that you're giving on this patient?
Ooh. Well, in a sentence or two, I think I'm going to do CBC. I'm going to do a complete metabolic panel. I'm going to send a chest X-ray, blood cultures, fluid bolus. I'm going to send a lactate because I'm worried about sepsis, and that's one of the quality markers. One of the things we're going to use to guide our resuscitation for septic shock. 2 large bore IVs. We're going to have a discussion about how to oxygenate him, but he clearly needs to be oxygenated. And I think I would probably, I would really have a high flow nasal cannula near the top of my list of how to oxygenate this guy, considering that he's already refractory to some of the other things that we've done.
All right, good. So a lot of stuff that we're starting up front. So Scott, I'm going to move this off to you. So we're balancing testing and expediency, right? I mean, to me, this feels like very much of a clinical diagnosis we're going to make initially with our bedside exam, but there are obviously other things, adjuncts, not just a stethoscope and a history, because this guy's not giving much history at all. Where are you going as far as the initial stuff? You walk in the room, you obviously realize this guy's sick. They've sort of done everything they can in EMS, and he is still not doing well. Give us your approach.
Yeah, well, I don't carry a stethoscope. I don't really believe they're helpful, so that's not even going to take part. And history kind of drops away a lot when they're critically ill for the initial stabilization. So this patient needs their blood pressure stabilized. They need immediate stabilization of their saturation, and at the same time, they need rapid diagnosis. And the only way to do that is by ultrasound. And so they need a rush exam and a blue exam. The rush exam for hypotension to figure out why he's hypotensive, and the blue exam is just basically a very rapid lung protocol, because if I see, the lungs are filled with fluid, well, okay, then it's either pneumonia or it's acute pulmonary edema. On the other hand, clear lungs push me towards pulmonary embolism, and I'm going to go in an entirely different direction. And then with that hypotension and the possibility of intubation in this guy's future, I got to make sure the right heart is not enlarged, because that is an entire branch point from what I could do safely versus what's going to kill him.
Well, since you went there, Scott, I'm going to sort of get to the next sort of point of your statement there. You have this patient, you do an ultrasound, and you see evidence of right heart strain. Are you pushing a thrombolytic with a bedside clinical diagnosis of PE, or would you first get the guy over to do a CTA to confirm that there's a PE before you would give a thrombolytic.
Yeah, that's not enough to give
Okay.
a thrombolytic, in my opinion. If I saw that and I had this story and then suddenly he went in arrest, I think that might push me to say the
Right.
risk benefit changes. But there's a lot I could do to stabilize him if it is a pulmonary embolism, and it's the same stabilization I do for right heart failure in general. And I think you can get this patient to CT. So no, I wouldn't push a lytic based on that alone.
Yeah. Okay. And of course, like if he just had surgery in Australia, flew back to the United States, and has one swollen leg, obviously it's a little bit different story. A lot more supporting evidence to something like a PE in that same situation.
I don't think I'd empirically push a lytic unless
Okay.
there's something precluding me from getting a diagnosis.
Okay. Good.
Scott,
Well, I'm glad I asked
Scott,
that
you mind if I
question.
jump in real quick, Mike? Scott,
Yeah, man.
in this patient, you obviously wouldn't, and I wouldn't either. But if it was a patient that had a pretty convincing history for PE, and then you found right heart strain in a hypotensive patient, would you do a lytic in that point, or would you still be working to stabilize and then confirm?
Well, I mean, there's depending on the clot burden and where it's at, there's other modalities that may be a better choice. Now, if I can't temporize the patient by increasing their perfusion of the heart and fixing some of that right heart strain and getting the patient stabilized, and they're continuing to go downhill, once they're pericode, then the entire paradigm changes, and then I don't want the patient to arrest. And with the supporting evidence you just gave me, that might push me to give a lytic before a formal diagnosis.
So Raj JEsudoss, let's bring you in, Pulm Crit Care, and I want to ask this question. We have a patient coming by EMS, and I told you they had initially tried some CPAP, and now he's on a non-rebreather mask, and certainly we could go to CPAP or BiPAP if we want to at this point, but it's a hypotensive patient, 81% on non-rebreather mask, tachycardic. What are some other things besides BiPAP? Because obviously most of us are going to move straight to that, but some other things that you would consider doing prior to intubation. Then I'd be interested in your thoughts. If those things don't work, do you intubate now or try to figure out a diagnosis? And if we're able to get him a little bit better based on that diagnosis before you'd intubate?
I think I'm walking into a patient, looks like even a competent guy with not but COPD, CHF, and looks like his window of non-invasive ventilation is very narrow. So if he doesn't, because we cannot whole lot, we cannot increase the EPAP because that is going to reduce the venous return and your blood pressure. So we don't have a whole lot of wiggle room. And even a competent host and you get a chest X-ray or the ultrasound bilateral, you think it's pneumonia, pulmonary edema. If you think you cannot salvage much, we can do EPAP or because I don't think BiPAP, unless he's hypercarbic, I think we whole lot, we are so very narrow. I think I will more inclined to, if he doesn't respond in within 30 minutes to 1 hour, I will straight away make sure there's no PE as we talk about what induction agent you go in the setting of RV strain and everything. And I had a similar patient. I was moonlighting. I was a pulmonary critical care fellow that was in Southwest General in Cleveland. I had the same patient, and I did two things. I scanned his DVT, and I looked at that RV strain, and I couldn't compress one of the femoral vein, and I knew there's no time for sending him to CT scan. I gave thrombolytic at that point, and so I called the pulmonary attending on call. He agreed with me, but it was a little bit a tough decision to make. And at that point, the patient is crashing, and your window is very limited. I don't think non-invasive is going to quickly turn around in this guy. If you're reading with a EF of 20%, a CHF guy or COPD, there's a high chance they're not invasive. But this guy, I don't think, I'm not entirely confident the NIV will turn him around.
So we're going to want to stay close with this guy. And, I'm curious also, Scott, moving things back to you. In the olden days, you shoot a chest X-ray, you get a wet read because it's got to be developed and all this kind of stuff. These days, I mean, though the chest X-ray isn't going to show you all pneumonias or maybe even things like cardiac tamponade, etc., but we would get some information from a chest X-ray, especially because they can do that, and you can see the image on the machine in the room, actually. How much credence, Scott, are you placing on that chest X-ray? If it's totally negative, I would think that would increase our concern for PE, and then probably decrease our concern for things like obviously pneumothorax, large pneumothorax, tension pneumothorax, or things like congestive heart failure.
Yeah, I think you're done with tension pneumothorax. I think you're done with CHF. PE becomes more likely when the chest X-ray is clear, but pneumonia is not out of the picture.
Right.
But the nice thing is the paradigm of, wow, now this is a PE forces your hand to go to CT scan, and then that's when you find, oh, it's actually a pneumonia. And I've been surprised how extensive pneumonia could be that looks, even in retrospect, okay on chest X-ray. But the answer is, when you don't have your answer from the chest X-ray, you got to get the patient to CT scan. And you always do it PE protocol, and then you get pretty much all the answers you need.
And so just to follow up to that before we get to Kay Moody talking about ABG and VBGs, Scott, two things actually. One's a question from one of the attendees, but the question I have is, people talk all the time, the circle of death, donut of death. I mean, I talk about that also, of course. It feels to me like if you have this critical patient and you go over with the respiratory therapist, with the intubation kit to CT with them, I mean, CTs are so fast these days that you can just shoot a quick, I mean, I'm not waiting for like labs or creatinine level. I mean, of course, but you can shoot that CT and they can be out of that thing in like 3 or 4 minutes. To me, it feels like the amount of information that you'd be able to get after your initial negative, I shouldn't say negative evaluation, but after your initial evaluation where you haven't come up with a really good diagnosis, to me, it feels like risk benefit wise, I'd like to get that patient over, but I'd be curious for everybody's thoughts on that.
Well, so the problem is, and look, this was like episode number 3 of MCRIT, so it's at least 13 years that I've been saying this. You can't go CT thing is bullshit. This patient's a little bit different. First of all, you have very low odds of getting respiratory therapy at most hospitals to be able to transport the patient on BiPAP or CPAP or even high flow, though they should be able to do the latter. And if they can't, it's worth working towards that. So then you have to decide, should I just intubate them for the CT or am I going to try them on a non-rebreather? This patient's proving non-rebreather is not going to work. The other thing is this patient's probably sitting up right now. And you have to do a real road test of whether they're going to be able to lie down and not crump. So I will take any sick, trauma patient, aortic dissection to CT. That's what they need. This patient needs a little more temporizing, I think, before you go.
Gotcha. So KK, you have been so patient waiting over there, and I wanted to sort of, well, actually, let me pull the listener question. We'll do that in just a second here, but I wanted to KK ask you because Mike had mentioned some different things, some markers like lactate level and blood cultures, which obviously aren't going to help even while they're in the ED, but ABG versus VBG. I have been very reluctant, for quite a while, to do ABGs because it feels like we don't get any more, in general, information than a VBG plus a pulse ox, and it's such an uncomfortable procedure for a patient. But you have a study that you're going to talk about here by JEsudoss, where actually the correlation between VBG and ABG was looked at.
I was totally surprised. Can you hear me okay?
Yep, perfect.
So I was kind of blown away by this study because similarly, of course, I hate doing them. I hate doing ABGs because they're painful, but I want the information. I need to know how they're doing as far as their acid base, their ventilation, their oxygenation, and I need the pH, I need the PO2, and I need the PCO2 to kind of make some decisions on where we want to go with these critically ill patients. But this study, surprisingly, was comparing using comparing an ABG to using a VBG plus a pulse ox. And they said that the pH varies only by about 0.03 for the pH for the VBG versus the ABG. So just knowing that's going to be the difference and you're aware of it, as well as the the PCO2 varied by about 4.8. So if we know the normal is, around 40, just sort of add approximately 4 to 5, 4 to 6, to it. And then you can sort of use that as your new normal for the PCO2 when you're analyzing it. And then also using the pulse ox, because they found in the study that the SpO2 was pretty equal to the PO2 of the ABG when you use the pulse ox, just the SpO2 and the pulse ox. So they did 156 patients. They analyzed 129. It was a prospective study in a single institution. So I mean, why do we need it? We all know we need the acid-base ventilation, the oxygenation. Why do we not want to use it? Why are we looking for an alternative? This use gives it an alternative way that's a little bit safer, a little bit less painful, a little less invasive.
Okay, Weingart, weigh in.
Yeah, I see no value to ABGs unless you can't get a pulse ox. And when you can't get a pulse ox, it almost always is not respiratory. It's hemodynamic. They're not perfusing their periphery, and they don't need actually BiPAP or augmentation of that. They actually need usually a push dose pressor or some form of volume expansion, because that's why you don't have a waveform. So otherwise, VBG is fine. Now, in many of these critically ill patients, in the first 15 minutes, replacing an art line in their radial artery, it takes about 60 seconds or less with an ultrasound, and then we just use ABGs. But I would not stick a patient for an ABG, just like KK said.
Gotcha. Pallaci, yes, agree, disagree?
100% disagree. I haven't used an ABG in a patient where I had a good pulse ox and who wasn't on a ventilator or didn't have an art line in probably, 10 years.
So you
Gotcha.
agree?
So
You don't
you
disagree.
agree?
100% agree.
So with
Did I go
We disagree that you
150%?
disagree.
Is that-
So one thing you want to think about, though, it's not going to be 100%, because if you have somebody, blue, the whole methemoglobinemia kind of thing, or carbon monoxide. I mean, there's going to be, if you have some sort of shift in your oxygen dissociation curve, of course, it's going to be a little different. So it's not going to be 100%, but for most of the patients, that's not the case, and we can use a VBG instead.
Yeah, it's a great point, but those actually would require a separate test, a co-oximetry, and those also could be done venous. So it's a fantastic point, but that also won't involve sticking the artery.
So Raj JEsudoss, I do not know where you stand on this because we have not spoke, but I think most emergency physicians are really pretty down with the VBGs. But you, being Pulm Crit Care, and I know that sometimes a lot of times I still get hospitalists asking me what the ABG showed, or asking me to write for one, and I then say, can I, I'm just doing a VBG, whatever. What is are you familiar with this study? Were you surprised by the study if you weren't? And what do you do?
I think in our critical care world, either it's a post-op patient, most of them has A lines, and I think physiologically speaking, there's most of the population doesn't make a big difference, but certain subset with severe septic shock, or you can pick up a pulse ox or alkalemia, or Dr. Moody said about false high SpO2 PaO2 correlation, methemoglobinemia, carboxy. So very specific situation where severe septic shock, the O2 extraction ratio is so high. So sometimes it's that's the only time I will do an ABG physiologically. But we do always ABG in our world. But by looking at all the things, I agree. VBG in most case scenarios is sufficient.
Good. And so now that you say that, I'm going to have you on record here. I'm going to play it back to your hospitalists. Just kidding. Just totally kidding, Raj. But it's a really good point, because of course, if you have an A line, but the fact is, like, you're sticking to patient, and like the respiratory therapist often, I got an ABG. It's like, oh, really? So anyway, this is a nice point. I think is just a little bit of a branch point. So quick question back to Scott here. From Jennifer Macagnago in the chat. Would you do a full rush exam, including aorta, Morrison pouch, bladder, etc., or just cardiac, lung, and IVC in this case?
Yeah, no, it's a great question. I don't do all that crap. You could actually listen to the Rush Redo with Jake Avila, where I explain why those additional fast views are dumb in trauma and for Rush. So I always look at Morrison's. It's nice to know if the patient has intraperitoneal fluid. In this case, it could probably be a medical reason, cirrhosis or what have you. Why not look at the aorta? It takes 10 seconds. And I definitely want the IVC in this patient, not for their hypotension alone, but also for what the hell's going on with their lungs and right heart and volume status.
So guys, it is time to see what actually happened at the bedside. We talked about CT already, but here's what happens in this actual patient with this actual documentation. The labs returned 545, hemoglobin 12.3. The sodium's, basically normal, a little bit low, whatever, 130. Carbon dioxide 20. and glucose and troponin. I mean, none of these are really giving us a great answer. Lactate is a little bit up 2.6, but not super concerning. Hard to say what that actually even means. Chest x-ray actually, as it's read, worsening airspace opacities, which may be progressive pulmonary edema or widespread pneumonia. Thank you very much. I'm sure clinical correlation was required. And the physician then says, 57 or 6, whatever year old man, he's talking respiratory distress, breathing 40 times a minute. They did get an ABG, showed he's not acidotic, EKG, sinus tach, but no specific changes. And they include basically everything that can cause shortness of breath in the differential, including ARDS. They said we'll get a CT angio to rule out PE, but it sounds like not yet intubated that patient. Now, sometimes, you come away from the room and they're still satting around 90, even on all the stuff in the BiPAP, and you're like, well, at least they're staying there. They're not going lower. Still super concerning. There's no wiggle room there, but I can see sometimes how this might be done. So anyway, they put pneumonia is high on the differential. He has just been on Levaquin, so we put him on broad spectrum antibiotics. So we're at decision point B here, and I'm going to start off with you, KK. Well, actually, here, let's see here who is perhaps. Let me start off with Scott, actually. So we get some more data. This isn't just our bedside stuff, but other data with labs, chest x-ray, et cetera. Has our differential changed? And why are they putting ARDS, or why are they putting that in the differential? I'm assuming that's because of the chest x-ray findings.
Well, so a few things. I mean, PE is less likely now. You'd have to have another process to be giving you those infiltrates. ARDS is really a severity marker. It's not a diagnosis. There's something that would be causing the ARDS, so that's in there because this patient has obvious hypoxemia that's pretty severe and showing shunt physiology, but that doesn't help you. That's just how severe their lung disease is. I would have given this patient antibiotics at the door, and the rule for me is if you have hypotension and you don't have a clear reason, then you just give the antibiotics. Easiest thing in the world. It'll save your ass so many times. It's just not even worth thinking about. It's unexplained hypotension. It's always sepsis until it's not.
Mike Pallaci, give me some thoughts on that, as well as some of the different examined test findings that maybe not now, but maybe even when the patient had walked in the door, which could have been present that could have helped you. And I know that, Scott, we talked about stethoscopes in the past. I'm not saying I'm a huge fan, but I'm just saying that, sometimes, rarely, but sometimes we find something. I had a patient, this was like 600-pound guy who the paramedics got him. He was like pre-arrest. They like dropped him as he was trying to come into the place. They had like all the staff ran out there trying to get the guy on the gurney. And when he got back to the trauma room, which is where medical stuff goes too, he turned out to arrest right at that time. Well, as it turned out, the guy had surgery 5 days before. He had a swollen leg, and now the guy's in arrest. So we did our critical care bounce backs just last month about treating PE arrest with thrombolytics, and I think we all agree that we're doing. But my point is that sometimes we're going to find something, and this guy had that swollen leg, and we had something on the history with the recent surgery. So Pallaci, I know long answer, short question, right? But or the opposite? What are some of the things that you might find by looking at that patient that could help with the diagnosis?
Well, looking at that patient or looking at the results we've gotten back so far, I mean,
Yeah.
I you know me well enough to know I can't resist an opportunity to take a swipe at the white count. I think the guy can go home. I mean, his white count's normal. He's not sick, obviously.
Right.
So yeah. So I mean, the inflammatory markers really aren't all that helpful in any of these scenarios, and that's a point that we try to make over and over again. In terms of determining the etiology, I mean, it seems pretty clear with this chest X-ray. Yeah, he's in. It's either diffuse pneumonia, ARDS, pulmonary edema hasn't completely been ruled out, but we're really, given the clinical history, this really seems like this is pneumonia gone wild and he's in ARDS. So in terms of chest X-ray findings, I mean, or in terms of determining what's the source of the pneumonia, in terms of bacteriology, it's really not the chest X-ray is really not very helpful in that. Sometimes it can give you clues, like if there's cavitary lesions can point you a certain direction, or certain findings that we're taught to look for with Klebsiella or things like that. But the chest X-ray really doesn't help to sort that out. The inflammatory markers really don't help to sort that out. So we're really going to shoot with broad spectrum antibiotics and treat him as a sepsis patient, as Scott says, until it's proven that he's not.
Okay, so regarding those antibiotics, let me I think we'll all probably agree on this, but I don't mean to put words in anyone's mouth. But KK, let me bring you in on that with the antibiotics. Scott was very upfront with, you got an undifferentiated hypotensive patient we're getting that patient on antibiotics. Because the data will show that about 50% of the time, that's the data that I'm familiar with, maybe Scott, you have different data, that will be from an infection or from sepsis, septic shock, right? So we're not talking about like a motor vehicle accident patient or someone who had their like arm chopped off in a wood splitter or something, right? But those undifferentiated hypotensive patients, what is your process? I mean, is it the same as Scott's to give that patient antibiotics right in the door? And I'm not talking about quality markers or getting like that nasty gram letter in the mail, but I'm talking about what you think is best for the patient.
Oh, without a doubt. Absolutely. And especially, we don't even know the temperature of this patient yet. That still bothers me because we still don't have a temperature. But definitely they have tachycardia, they're hypotensive, they're in respiratory distress. Even before we know anything, even if we don't know they have a temperature, I would definitely give this patient antibiotics without a doubt. Probably something very broad spectrum, maybe vancomycin.
Okay. Raj, I'm going to ask you your thoughts on that, and then we're going to move to the intubation question to find out what happens after this. Well, I won't ruin the surprise, but after the patient was intubated.
I think the chest X-ray antibiotics is no brainer. It's just it should be a reflex now. I won't even think if you need to shoot the antibiotic as soon as possible. But I'll be getting my intubation tray already because the chest X-ray is pretty awful. I don't think the even a competent guy with this. With the way he's trajectorying, I will secure the airway as soon as possible. Yeah. Mm-hmm.
Yeah. This does not seem to me like a reversible, like an immediately reversible process. I mean, we've had these pulmonary edema patients, and sometimes it's like magic. They get better, right? You temporize them with that BiPAP.
Yeah.
Yeah. Mike, did we ever get an actual echo? I know we were positing what if, but this could also be cardiogenic shock unless, this patient you'd expect to have a hyperdynamic heart with arterial vasodilation if it truly was sepsis with pneumonia. But if on the other hand, patient's all vasoconstricted and the heart looks like garbage, then you have to consider that it's actually the heart.
I think that's such an important point, Scott, because we don't have any ultrasound information anywhere in this case, and if there was something that stood out like a sore thumb on that initial rush exam, on an initial ultrasound, it might take you a different direction. But absent that information, I agree, we got to hit them with antibiotics early. But the ultrasound information really is a great early branch point as far as where you might go with this.
Yeah, and ultrasound was not done actually on this patient. So it's a real case. All the stuff that we're showing you is real stuff. Here is what happened then after this branch point. The medical decision-making says the patient does not show any obvious PE, bilateral infiltrates concern for ARDS, adding a flu swab, severe hypoxemia with repeat blood gas. And this was before the age of COVID, by the way. PO2 of 63 and 100% FiO2. BiPAP will intubate for severe hypoxemia. They gave 15 of etomidate, 100 of Sux, and an 8.0 ET tube was placed, 22 at the teeth. Sound like it was a pretty easy intubation based on this note anyway. They said, though, given that his SATs were as low as 20% after intubation with bagging, a code was called, and the ICU and anesthesia folks came down. Never lost pulses, never had an arrest. So let's now move to our decision point C. I would guess that we're all pretty good with these medications used. And I have to say, just as a personal caveat, I mean, for like 20 years, I was like a Sux guy, not because I thought it was so great, just because I always used it, never really had a problem. And I have to say, honestly, and maybe I'm like totally wrong with this, but it seems to me when I use Rock, which is basically the only thing I use now, I don't feel that there's any delay in that patient becoming paralyzed. Like I tickle their eyelashes and within, easily less than a minute, but sometimes faster than that. So it sort of feels like at my bedside experience, Rock has definitely not had that downside as far as the delay in time to enable me to intubate that patient. Anybody have thoughts on Sux versus Rock in this situation?
I'm the biggest proponent of rocuronium, and it's not even up for debate. The literature is clear. If you use the right doses, Rock will be nearly as quick as succinylcholine. That's not the problem. The problem is if you're an amateur player on resuscitation is that these patients won't get sedation post-intubation with Rock. And a number of studies published showing that patients, will be 40 minutes on Rock before they actually get sedated just with their etomidate, which wore off after 5. So if you're not playing an expert level game, you sucks, because then the patient will wake up and tell you they're miserable. If you're going to use Rock, you better have the intubation, post-intubation sedation in the room before you start the intubation.
I love that point. And I'm guessing well, tell me, what do you use for sedation? Then Raj, I'd be interested in your thoughts on what you use for sedation. Immediately
almost
after intubation.
yeah, almost every patient is going to be propofol to start, and then depending on the situation, we'll either switch off to dexmedetomidine or we'll stick with propofol. But propofol is the drug of choice, and if you need to use pressors to get the patient's blood pressure where it needs to be in order to use propofol, then you just do that, and you have no compunction. And in fact, we'll ask the nurses to bring the norepi in the room as soon as we intubate, and tell them anytime the MAP's less than 65, just start it. You don't even have to ask, and then that takes away their fear because they'll otherwise turn off the propofol instead of increasing the vasopressors.
I have definitely had that happen. And then sometimes you find out about it a little bit later.
I need to keep the norepinephrine drip, definitely. Yeah, it's a propofol. A propofol is a severe myocardial depressant too. So in case you're running into hypertension, the second line will be Versed and fentanyl. So I have used it a lot. When I was an anesthesiologist in critical care, I used to use a lot of second line Versed and fentanyl. Even for induction, we do for EF of 10%, we dose high dose Versed and fentanyl. We don't have etomerate in Europe, so we do that. Or ketamine, we use that in this kind of situation. Rocuronium, agree, ED95 dose, 1.2 milligram per kilogram body weight. We'll have an ideal intubating condition like succinylmethonium, and I won't. So it depends upon preference of the intubator. Definitely Scott, because elimination of rocuronium takes longer time than succinylmethonium, so we need to make sure they are on appropriate sedation. Yeah.
Gotcha. KK Moody, you're just not the best thing to use, but what do you personally use? What's your go-to agent for sedation post-intubation?
Oh, sedation post-intubation?
Yes.
Oh, okay. I thought you were talking about intubation. Yeah, I kind of go for Versed a lot. I'll do a bolus of 2, and then I'll put them on a drip of 2 an hour unless they start bucking the tube, and then I'll increase it.
So I have not done that. To me, I use Versed obviously other times, but have you had good success with those doses? It feels like maybe I would think of a higher dose. I mean, sometimes the paramedics even like give 5 or something. They'll tell you they gave 5 for a seizure. I was like, that seems like, a lot when you're driving, 80 miles an hour down the highway. But you've found good success with the Versed with that, huh?
Yeah, sometimes. I mean, my thought is you can always put more in, but you can't take it out. But of course, they're already intubated, so it's not like you're going to bother with that. You're not going to make them stop breathing. You're breathing for them. But I like to go small a little bit in the beginning, and if it works, it works. And if it doesn't, we give more. And so I'll do a bolus of 2 and then order the drip. And then if they need more boluses while they're still in the emergency department, I'll bolus more. Of course, usually by the time they go to the ICU, they'll switch it to propofol, or somebody, an ICU doc or one of these guys will change it to something better.
Right,
My only
exactly.
fear is if you did use rock, then those doses are probably going to be inadequate, but you won't be able
Well, yeah, that would be that. No, that would just be rude, right? Because if they're paralyzed and not sedated, no, that would be terrible.
Okay, I just wanted to I like the controversy a little bit here. So,
Yeah.
Raj, your thoughts on the Versed?
Versed and fentanyl. When you add fentanyl, it causes the additive effect, the pharmacokinetic. So your Versed dose, but the Versed also causes antegrade amnesia. So, that will come for an advantage. But definitely, we need to get the Versed dose right, 0.25 to 0.5 milligram per kilogram body weight. And fentanyl also will help you to reduce the dose of Versed hemodynamic. When compared to propofol, the hemodynamic effects of Versed and fentanyl is a little bit tolerable than propofol. Propofol makes the BP fall. That's what we say in anesthesia world. Yeah.
Propofol makes the BP fall.
Yeah.
I've not heard that, but I like that.
When I say it's rude, I mean I would be rude as the physician to paralyze them and not
Right.
sedate them.
Yeah, we got you.
No, we knew what you meant. Yeah. So and not that anyone cares, but I'm pretty much like a propofol guy, and I have to say I give a bolus and I give a drip, and it usually works. So all those things, all good, and then I'll oftentimes add in some fentanyl to the patient, post intubation. So speaking of intubation and speaking of our actual patient, this was curious to me. They said that the patient, who was sitting at about 90% on BiPAP, got intubated, and then he went to 20%. So the last 2 really big points, and I'm glad we have some time that we can discuss both of those, is I really want to do a deep dive into post-intubation hypoxemia and post-intubation hypotension. So I'm going to throw this out first to Mike Pallaci, and then I'd be curious in all of our thoughts on post-intubation hypoxemia, because when this happens, I mean, it's sort of like this is the thing we're going to, and then all of a sudden now the patient is either worse or not improving. So Mike, give us a couple minute talk or thoughts on post-intubation hypoxemia, how that's addressed, what are the most likely culprits?
Sure. So I mean, I learned all this before. I'm not a big fan of mnemonics, right? And there's a lot of reasons for that, but I actually learned how to manage this before the advent of the dopes mnemonic. Now, I'll tell you that if I was going to advocate for the use of one mnemonic in medicine, dopes might be it. But as we kind of go through it, we'll kind of see some of the drawbacks of using a mnemonic for something like this. But yeah, I've just through experience and the way that I was trained, I've learned to kind of work all these things just into my general approach to the patient without having to use a mnemonic to fall back on. But dopes is, if you're going to use one, this is the one. So the D in dopes stands for displacement of the tube. In other words, have they been inadvertently extubated? O is obstruction. So is the tube kinked or is it blocked by a mucus plug? P is one of the reasons why I'm not nuts about mnemonics. There's so many different P's. You can summarize all of them in patient related, but some other when you look up the dopes mnemonic online, some of them will list a few different P's like pneumothorax, pulmonary embolism, pulmonary edema. Worsening R's doesn't really start with a P, but that would kind of fall under the patient related complaints. So when there's multiple different letters like that, I tend to have a hard time remembering which one or which words I'm supposed to remember for that letter. But P for pneumothorax, PE, pulmonary edema, or you could just remember patient-related issues. The E in dopes is for equipment. So did the cuff get torn? Is the ventilator disconnected? Is the oxygen out? Is the oxygen disconnected? And then finally, S is for stacked breaths or auto PEEP. And that's a relatively easy fix if you are able to suspect it early and diagnose it. It's basically disconnect the patient from the ventilator, manually decompress the chest, and then rehook them back up with different vent settings to try to prevent that from happening again.
So I want to bring Scott in and Raj also on this because, patients that are intubated can still die, right? So it's not like the fact that you're ventilating a patient saves every single person's life because they can have some bad, obviously, underlying processes. But in this guy who had a SAT go down so quickly, and say we saw the tube go through the cords, we have good, moisture in the tube, it's going, we're getting air in and out is what I'm saying. I just want to think about some other specific things we could do once maybe even we've moved past the dopes mnemonic, Scott, as to what are things like, would you ever prone a patient actually in the ED? What are some more common things that we can sort of do as far as thinking about this? And then the correlator of the question is, and I don't know this for sure, but my suspicion is that most of all of us in emergency medicine intubate a patient, do like some sort of like in our brain, air high five, whatever, drop the mic, walk out of the room and let the respiratory therapist take over. So I'm not saying that that's wrong, but I'm saying, at least in my experience, it seems like that's usually how it happens. I'm not aware of any data that shows that's the case, but tell us what you would do first in this situation, but also how intensive you are with specifically giving guidelines to respiratory as far as the vent settings.
Okay, many things here. First of all,
I have another question.
Okay. Well, first of all, what that 20% almost certainly is a phenomenon called pulse ox lag, which is when you look at the pulse ox, you're not seeing what is now, you're seeing what is 60 to 120 seconds in the past. Okay. And the more hemodynamic instability, the further in the past it is. So this was, the 20% was what they were intubating at, and they were all happy with themselves that they were maintaining a SAT of 85. But that's because the pulse ox was lagging. So that's what they were seeing almost certainly. Now, the dopes mnemonic is good, but most of it is obviated by just seeing end tidal CO2. And that immediately differentiates whether gas is getting into the lungs or not. And that it immediately cuts through the bullshit. And for me, Mike, the P has always just been pneumothorax. The other stuff, I don't know where it came from. That's not my dopes, and that's not how it was originally created. So the origin is easy, and it should make Pallaci happy because the P is just one thing. It's pneumothorax. Again. Most of that is a remnant of the days when people were using 14 cc's per kg and they were busting lungs left and right. It's a lot less likely. It's still possible. You can rule that out with ultrasound. Now, the most common thing you see on a patient like this is when they go from negative to positive pressure. In addition to hemodynamic stuff we'll talk about in a second, you actually can have a significant worsening of your hypoxemia. There's a number of effects that will cause it. But negative inspiratory pressure is a recruiting mechanism. As soon as you put them on positive, they have a tendency to de-recruit unless you picked the right PEEP level. And most ED folks don't go high enough because it's scary. In general, this patient should have been optimized at whatever PEEP they needed beforehand. And that could be quite high. And a patient like this could even be an EPAP of 20 just to temporize them for the intubation. I wouldn't leave them there. And Raj alluded to this earlier, and he's absolutely right. You're not going to leave them on BiPAP at that kind of level. But for the intubation itself, getting them up there to get their SAT to 100% before the intubation will also give you where to have them post-intubation. And most of the time, when you see a patient like this crashing after the intubation, it's because the PEEP is way too low. So do the doped mnemonic, just like Mike said. And then what they need, if they are getting end-tidal CO2 and the tube is good, is you need to up-titrate their PEEP very rapidly until you start re-recruiting the alveoli you lost during the intubation attempt.
Nice. Raj, you are obviously, this is like your bread and butter.
Yeah,
Thoughts
so
on what Scott
that's what
says.
I intubate in the ICU because now it's COVID 2 years. So this is a common theme. After we intubate, the saturation doesn't come for almost 1 hour, sometimes 20 minutes, and people did well, a lot of people. So the one thing to add on, I will look for the right main stem intubation sometimes. I put the vascular probe. I see the lung sliding on both sides is equal. Then I can see the ETCO2 if there is obstruction there coming from one main stem. I can see that. So that's one thing I will add. The next thing is we need to get the hemodynamics pretty good on a lever fed with a preload with fluids and get the optimal PEEP. What in the ICU, what I will do to get the optimal PEEP, I use the ETCO2. So once the PEEP is gone, and we'll watch the CO2, when you overshoot the PEEP, the CO2 drops. That means you're compressing the pulmonary capillaries. So that can be more harmful, and that can cause your PA pressure to goes up and your right ventricular output can go down. So that can counterproductive. So to finding the optimal PEEP is very key in this patient. And after giving optimal PEEP, after 20, 35 minutes, if the patient is not doing well and the hemodynamics is relatively stable and a stable vasopressor dose, I will prone this patient because your transpulmonary pressures are very high on the ventral side, lower on the dorsal sides when you flip. That's what I did for my COVID patients mostly. This is a common scenario we encounter. And we paralyze to take out all the oxygen consumption out of the skeletal muscle mass. These are a few things. Yeah.
Okay, gotcha. So now I want to just, before we talk about the post-intubation hypotension, a question in the chat on Precedex for post-intubation sedation. Anybody that wants to talk about that? I have not used myself Precedex in the ED. Is that a common thing?
Yeah.
Or what do you guys think about doing it?
Yeah, Precedex is a great drug. So it's a central alpha-2 agonist. It is 10,000 times potent than clonidine. So, but the main thing is Precedex, because the central sympathetic light blockade, right? So you get into hypotension and bradycardia in the setting. So you need to be careful. But that's a choice. But usually we go propofol and Versed in this time. Yeah.
Scott?
Yeah, Dex is a wonderful drug, and actually, when compared to propofol, has at least as good salutary effect on the hemodynamics. It's probably a little bit better. And I'm not a big fan of benzodiazepines at all. We have, I think, pretty clear literature and guidelines stating that patient probably shouldn't be sedated outside of a few edge cases. So you're pretty much dealing with propofol or dexmedetomidine. The problem with Dex in the ED is it's not a rapid acting drug. And Raj alluded to the hemodynamic downsides. Those are all from the bolus, which none of us do anymore. So getting them just up to levels on the drip takes a while. So even on patients I want eventually to have on dexmedetomidine, I'll start them on propofol.
Gotcha. All right, let's move on here. And thank you so much for that question in the chat there on the Precedex. So this is a mnemonic that you need a mnemonic to remember the mnemonic, right? So this is the post-intubation hypotension. So why don't we just sort of go right to you, Scott, and we're going to talk about this, and then I'm going to ask KK to just give us like a 60-second summary of a recent article that came out in patients who are intubated who we see just incidentally a pneumothorax. But first, Scott, post-intubation hypotension, a little different problem than a post-intubation hypoxemia.
Yeah, I mean, it's almost always physiologic from going from negative to positive pressure. it's going to cause radical changes in the patient's hemodynamics, and you should just expect it. And we like I mentioned, will have norepi in the room for any patient who is even borderline, and you should just have no compunction whatsoever about starting it, temporizing them, and then you can figure it out with a rush exam or repeat to figure out what is actually going on, because this mnemonic is just silly.
It illustrates everything that I hate about mnemonics, doesn't it?
Yeah, I completely agree with you, brother.
Raj, I'm sure you've had, especially in the age of COVID, obviously many patients who died from COVID, obviously in the ICU, intubated,
Yeah.
and those patients became hypotensive before they died. So it's the underlying process, but tell us your sort of, in your brain, your approach when you walk through this.
I think before I intubate, I just open the albumin, and there's there are a few Kay Moody and cohort studies starting Levofed before you induce, but in COVID, I always had a Levofed running a little bit before I even put the patient to sleep, and but there's no data behind it. But probably in the COVID data, hopefully it comes. And acidosis is a big thing. And usually in COVID patients, we didn't have much acidosis, but this patient, I'm not sure what's the pH. I'll keep the bicarb ready because most of the vasopressors goes to the cyclic AMP. If you have an acidotic pH, they're not going to work through the second messenger. So bicarb will give you a resurrection of your blood pressure many times. So then very important is pneumothorax and other things you need to think about post. But make sure the tank is full as much as you can and keep the vasopressors. I just started, but that's what I did in the last 2 years with COVID intubation, because I used to intubate 5 or 6 intubations a day, actually. So this method helped me a lot, yeah.
So let's do this, KK. If you could summarize this article, and then I'm going to come back to what actually happened with our patient, and we'll have some closing thoughts from everyone. So this is an article by Smith et al. And we could just honestly, like 30, 45 seconds, probably. Conservative management of occult pneumothorax and mechanically ventilated patients. So we're thinking about pneumothorax, that's in our mnemonic, but yet if we see one and it's small, is it really what's causing our problem?
Right. So we're talking about a really small one that you can't even see on a chest x-ray. This is one that's found subsequently on a CT that they had for some other reason, not one big enough to see. So they did 12 studies. They did meta-analysis. There were 3 randomized control trials, obviously not double-blinded, because how are you going to blind a chest tube, right? Can't hide that without great theatrics. 9 cohort studies. The conservative management, they said, was low risk of tension pneumothorax. Only about 2.8% had that. Complications with chest tubes, on the other hand, were 19.5% versus 5.8% with the conservative management. So it suggests that conservative management can be safe with occult, really small pneumothoraces on mechanically ventilated patients in the short term, less than 4 days.
Gotcha. Thank you so much for that. So I'm going to go back now and tell what happened to the patient. We'll get some closing thoughts here, and happy for anyone in the chat to ask questions of this really fantastic expert panel here. Patient was bagged aggressively. FiO2 came up to 85%. Still not great. Chest x-ray, E22 placement was good, but worsening bilateral pulmonary edema. The patient was diagnosed, this is what happened in the hospital, with, ARDS and acute respiratory failure, secondary multilobar pneumonia, and was sedated, treatment for community-acquired pneumonia, required vasopressor support, and had an extended period of intubation, eventually discharged to an extended care facility with a PEG tube. So obviously had some bad sort of effects from all of the process going there. So what I wanted to do is take this situation, and we talked in the beginning about the fact that obviously diagnosis was important here, but the management, obviously, what we thought we were so great at, the patient then became or remained hypotensive, but also became at least transiently hypoxemic after that intubation. And so, some of our intubated patients, we have an ICU like we do at Adena, which is fantastic. And Raj comes down, sees the patient, they assumes care, they get the patient up to the ICU. Other patients are sitting in the ER for 24, 48 hours, and we're still doing their sort of ICU management in the ED. And we don't really have to talk about the literature on that right now. But why don't we start here? And KK, if you want to give us some closing thoughts, some takeaway points, maybe 1 or 2 from this case.
Well, again, vital signs are vital. We never got a temperature on this patient. So I want to really, really nail home to everyone, always get that missing vital sign.
Gotcha. Excellent. Mike Pallaci, your take-home points.
I think it's two things that we need to jump on early that people that trained along, or might have trained several years ago might not have been taught to do early at all. Diagnostically, it's ultrasound early, like Scott really drove the point home on. It can give you so much information early on that there's no other way to get it that quickly. And then in terms of therapeutics, when we're intubating, really preparing for the hypotension that you should really expect with intubation, and having the pressure drip ready, starting it earlier, like Raj said, or my preference is really to use push dose pressures to optimize the pressure prior to the intubation, and then again afterwards if needed.
And what are you using for your push dose pressure and what dose? Pressor and what dose?
We have fennel sticks pre-mixed in our Pyxis and our
Okay.
ER where I work.
Gotcha.
So, and I'm a big fan of phenylephrine. Doesn't cause tachycardia. Push dose epi works as well, but you'll get some reflex. You'll get some tachycardia with the epi.
Okay. Raj, take home points from this case.
Yeah, I think it's a critically ill patient. So we need to have a plan A and set goals. If this vitals is not correcting within this minute, I need to go to plan B. So that's very important. That's what I always think. I go with the plan A. I know already set in my mind, I see for this parameters. If that doesn't work, I go straight away to intubation and stabilize it if you want to give CAT scan later. So that will be my approach. Is always have a plan A and a plan B, and have a set goals. If plan A fails, you need to get into plan B. Yeah.
Yeah, and actually that study by Hefner looked at post-intubation arrest and found a mortality for that, I believe it was 82%. I mean, like an incredibly high mortality.
Yeah.
So anything you could do to prevent a post-intubation arrest obviously is the way to go.
Yeah.
So Scott, you have the floor and the ending, and then I'll put the QC code back up there for people to if they haven't been able to shoot on that and register yet, so they can get the CME credit.
Yeah, well,
Bring it home, baby.
what this case brings up to my mind is that if you were to answer an earlier question that you posed, Mike, reliant on a respiratory therapist who just on that night happened to be brand new or inexperienced or just not the greatest, and that was where your entire vent management strategy comes from, then this patient's going to die. And it just brings up the point that I keep, saying on every single podcast, which is if you want to be a resuscitation doctor, you need to be self-contained and you need to know how to do every single thing a patient may need in the course of their ED stay. And if you're reliant on anyone, it's a very dangerous situation because you don't know what you're going to get.
There's a lot of nods yes on that comment. So thank everyone so much. Oh, Raj, go ahead.
I agree with Scott. I think ventilator man. That's why when the ER residents rotate with me, I want to make sure two things I teach them: how to ventilate a COPD exacerbation, how to ventilate a status asthmaticus, and how to ventilate an ARDS. Every ER physician should know without a respiratory therapist. Yeah.
There you go, man.
Yeah.
Yeah. All right. And a big applause for Mike Pallaci. So thank you everyone for joining. If anyone wants to see this that did not get a chance to, it'll be on the website EM Bouncebacks, emergency medicine. So embouncebacks.com. And that's also how you can sign up for stuff. I haven't done the QR codes for the fall conferences just yet, but that'll be on sometime in the next few months. But this should be up tomorrow or at the latest the next day. So thank you all to the panel for taking your time this evening. Thank you for the attendees who shared an hour of their lives with us. I hope it was worthwhile. And we will look forward to seeing everyone on September 5th. Thanks again, guys.
Bye, Mike, Scott. Bye.
Bye. Pleasure.
Bye.
Yeah, everybody.
You guys are awesome.
Keep that QR code up for a minute here if anyone didn't get an opportunity. All right. Anyone is still there? We will see you next time.